many of you know, I'm a clinical researcher, and particularly in cancer pain, and that has been much of the focus of my career. But in the mid-'80s, I had the opportunity to meet Jan Sternberg. And so I think in a way this talk is very much a talk that is a tribute to Jan, who had this wonderful sense that policies do make a difference. And so the short version of my talk is that policies do make a difference, but only if they're implemented. And policies can make a have an enormously negative effect. And I'll give you the examples, mostly of positive effects because I'm such an optimist. But there are some pretty negative policies out there that we need to deal with. So let me move. And this was Jan. So this is 1982, where Robert Twycars and I met with Jan and Vittoria Ventafrida. And Jan said that, what is wrong with you people? Nothing would make a greater difference. Nothing would make an impact than taking the knowledge you have right now to treat cancer pain and instituting it in the care of patients. And so as he was head of the WHO Cancer Unit, he had some power and authority. He was also extraordinarily charismatic, and he understood policy. So I'm going to talk about how, in a very narrow sense, how one type of policy, I've decided to talk about drug policy, has made a difference. And you can imagine drug policy at the moment is enormously controversial, where the war on drug every day is in our newspapers, and it is coming back again. And I'm sort of thinking the wonderful pendulum that swung in our positive direction is tending to swing back at us. So policies don't stay the same for a long period of time. And the policy was embedded in a three-step analgesic ladder that Robert, in drafting the first draft of the monograph, sort of argued very strongly for this ladder. And although this ladder still lives on, there's lots of debates about it. The recent EAPC new guidelines have held on to the ladder with a lot of debate about it. And new WHO pediatric pain guidelines have taken out the second step of the ladder. But whatever the case, the underlying science to the ladder still is there, and that we manage pain for mild, moderate, and severe pain, and we use drugs dependent upon the nature of the pain, dependent on the patient's prior experience, and most importantly, on the appropriate drug for that patient. And these were the monographs that over time morphed into a series of, and are continuing to change into new monographs that basically set the tone for what I would like to call the policy issue. And so this was the WHO public health model. This was Jan's really conceptualization, that if we were really going to be able to incorporate palliative care into any cancer control strategy, then we needed to have a very clear policy approach to how this would happen. And that policy would be very broadly a policy that focused very much on three components with this umbrella of policy within it. So it was drug availability, education, and then the process wonderfully of policy and implementation. And every time we entered an individual country and worked in a country, it was dependent upon the context of that country and where they were. And for the most part, this was focused on developing countries and countries with low resources, where clearly their ability to cure cancer was not possible. Most patients presented with far advanced disease, and the only opportunity then was to at least provide these patients with adequate care at the end of life. And so the focus at that point in time was that for very much in low resource countries, that palliative care should be an essential component of any cancer control program. So there would be early diagnosis, there would be some treatment, there would be clearly prevention, but that for the most part, palliative care might, in these low resource countries, be the focus of the intervention that the WHO Cancer Unit argued for. So with that, this model then morphed into even more detail, and this is from a paper that Frank Ferris, who is at the San Diego Hospice and runs a major international institute, and Jan and I worked on to sort of elaborate much more detail about this. And the detail was the detail of what do you do to really have a drug policy in a country? What do you have to do to really have palliative care policies as part of a national plan? How do you fund service delivery in these countries, and how do you create the policies? And remember, I'm just a doctor, I'm just a clinical researcher, and I thought that if you did good work, that governments would catch on and want you to do this. It was incredibly naive. And at every country level, we learned this, that unless we had this opportunity to really put together very clear policies and standards, there was no way that we were going to do this. And so as part of the funding that, I'm currently the medical director of an International Palliative Care Initiative, and this is funded by the Soros Foundations. And so within that framework, we made the decision that there was no way, with the limited funds that we had, that we could ever really support service delivery per se in a country. And so how could we make an impact in a country? How could we lead the country to the sort of next step of palliative care development? And so we decided that we'd create our palliative care roadmap. There's nothing original about our roadmap for anyone who does policy work. There are certain elements that always need to be part of this. And what became very clear to us that in the countries that we might work, and this was predominantly Central and Eastern Europe and Africa, which is where the Soros Foundations exist, that there were steps that we could take that might make a difference. And so we worked in countries where there were national champions. So there was someone that Cicely Saunders had once visited who had identified as someone who was the important leader, and that person had grown up, little programs in their countries, but were extraordinary leaders. We then supported, technically, with financial support, a clear country needs assessment, because this is, Irene is well published, the methodology for palliative care needs assessments, and we were taking this methodology to these countries and saying, how do we assess what the country's needs might be? And then, again, with support, we'd support national stakeholder meetings. And so we'd bring together all the stakeholders in the country, led often by the champion, but then with the government at the table, and support the government to come to the table to do this. And I can assure you this is difficult in some of the countries we work in, because they're not open societies, and we're the Open Society Institute. They're very closed societies, but they were willing to come to the table. And then we'd help them develop what was a palliative care concept. And for anyone that thinks there's anything glamorous about any part of this, there's nothing glamorous about it. It's hard, tedious work that requires lots of technical expertise, and in which the champions are like always saying, let's get on with the work, and everyone else is saying, could we please have the concept before we move this to the next step in the government? So I think I also learned that there was nothing, that all of this was about technical expertise in policy development at a country level. And if we don't support this, if we don't do this, we cannot help these countries move to the next step. So great champions are great champions, but they stay pioneers with every out-of-country program. And so every place where this has failed, it's because we did not succeed in getting the government on board at the right time. And so in this sort of elements of policy work, there are other sort of general principles. So the general principles, and I'll give you lots of examples, is there's a lot of symbolic language that you need to be able to move to the next step. We worked hard to help support the development of international documents to guide policy development. And my we is an enormous we. There are so many people, many in this room, who have worked on this that I can't begin to sort of list them, but I think you well know who you are. We needed these passionate, committed champions, and we clearly knew that they needed, and their governments needed, and their stakeholders needed financial support for technical expertise. And so with that, this is the roadmap. I don't really expect you to read it just to tell you that it looks complex. In a way, it's quite simple. It gets much more complex when I add this on, and I'm only doing this as a way to suggest that for each of these points on the roadmap, we're at one place or another in each of the countries we work in. And we're trying to tease apart, are such roadmaps successful, what makes them successful, and what makes them unsuccessful, and what lessons have we learned from that. And again, our own program has undergone an evaluation that's helped us sort of think about where and what are the triggers for better policy development. And I'll come back to that. So let's talk about symbolic language. This was an incredibly important report from the Council of Europe, because they came forth with a very clear recommendation that they said palliative care needs further development in Europe, and that there's insufficient availability of opioids. Governments are creating legal barriers, and they need to identify them. That legislation should make opioids available, and that the fear of abuse should not hinder access. And so this, in 2004, or rather 2003, was a really important document. And then from there, the International Narcotic Control Board, which is the particular board that controls the quota access of opioids to individual countries, came forth with a report that when we had criticized them for not having and paying enough attention to the availability of opioids, they came forth with a very positive statement that said the board encouraged governments to take steps to increase medical use of opiates. Well, the INCB has at best been difficult, but we continue to work with them and they continue to give this symbolic language. But I warn you about symbolic language. We continue to remind them of it, but it's been and continues to be a tough struggle. Interestingly, ECOSOC in 2005, we were able to get a United Nations resolution on the treatment of pain using opioids. And this is again with a lot of advocacy by a variety of different groups that argued that there were real impediments for patients not having access to pain-relieving drugs. And we saw pain relief as a major component of any palliative care policy. And so that we needed to have in place changes in drug regulatory environments to be able to do this. And smartly, the WHO and the INCB came together with a document that was called Achieving Balance in National Opioid Control Policy. So this was then a document that we had that was to guide how the WHO and INCB should, in fact, work and organize their activities with each of the governments they were dealing with. So that when we would go into a country, and I'll use Kenya as an example, they could use this simple document with technical expertise to look at the regulatory environment, to see what barriers they had, what regulations were in place, and how they could be changed. And although we still haven't gotten to a model drug policy law, we've worked hard to be able to move that forward. And again, I'll come back to that. In 2005, another important step forward to support the cancer unit was that the World Health Assembly adopted a cancer prevention and control resolution. And this was, again, these resolutions are important, symbolic language, because they then mean that some money infuses into WHO to begin to move these forward. And importantly, palliative care made it onto that resolution with a lot, again, of advocacy by many people here. 2010, more symbolic language from the Committee on Narcotic Drugs, which is a supervisory and advisory board to both the INCB and the WHO. But they're very tight in controlling drugs. And so they give this mixed message of, yes, we should have pain relievers available, but we want to prevent abuse. And at the moment, their language tends to be on the abuse side and not so much on the balance side. With funds from the National Cancer Institute and with that WHA resolution on cancer, our National Cancer Institute gave WHO funds to support how they could develop these simple documents on cancer control. And so this was the first on how to plan, and this is the last on palliative care. And what this document does is really embody much of the work that Jan had put forth, Irene's work on needs assessments, many works, Robert's work on what the kind of triangle should be, and how to be able to implement these programs. So this real sort of policy initiatives. And subsequently, there have been a series of policy documents that Irene and the Institute here has worked on to look at palliative care, the solid facts, palliative care in the older person, palliative care in the elderly, to be able to frame what should be the policy discussions at the WHO level that, in a way, constitute my view of symbolic language. So, in a way, we were getting a sense of urgency from these UN organizations with their symbolic language. We had the International Narcotics Control Board saying it was the right thing, the WHO, the World Health Assembly, the UN Economic and Social Council, the Committee on Narcotic Drugs. So this, who would be against us? And in fact, the problem with it is that there was nobody really against us. The problem was there was nobody for us. So, and I think it took me a while to understand that. So how do you get people to be for you? With that was, I think, really an unquestioned need to relieve pain. No one argued, no one stood up at meetings and said, we're for pain. There was clearly at that point in time a really very solid scientific and medical basis for what we were arguing for. There were clear guidelines from UN bodies. There was the International Narcotics Control Board that was now on our side, the World Health Assembly. And then what wonderfully emerged out of all of this, and again to the credit of my colleagues at Open Society, was the idea that pain relief and palliative care really were human rights issues. And so with that, we were sort of, Paul Hunt, who at that time was the special rapporteur on health, argued and supported us with the idea that palliative care is a human rights issue. He saw it very much embedded in the right to health, and more importantly, subsequent to that, Manfred Novak, who is the special rapporteur on torture, now sees that the lack of access to pain-relieving drugs in countries where other drugs are available on the essential medicines list is in fact could be considered as inhuman, cruel, degrading treatment, torture. So we've now moved to a much bigger agenda where pain and palliative care now are at the human rights arguments. And I must say that I wasn't sure how they would play out, but they are getting a little bit more traction than some of our other arguments. So we're working on those as we speak. And you're well aware of the different reasons for the unavailability of opioids, and I'm not going to take you through them, except country by country, these were the same reasons, well documented. So in every country, we looked at the barriers, we knew what the regulations were, we knew the issues, and they were anywhere from the inadequate method to assess need, to the strict regulations in the country, to basically the fear of physicians who would prescribe these drugs, and to lack of training in pain management and palliative care. So worldwide, these were, they might rank differently in a country, but these were the major barriers. They were very, very clear. And yet WHO had created this wonderful criteria for how to assess the policies that existed. And you could just literally go through this list. And so this is where I'm emphasizing the technical expertise necessary, because literally we would have to sit with the laws of the country that controlled the narcotics. Once we could find the official narcotic officer, once we could identify the policies that they had, and to sit with them and literally walk through what were the limits that they had. Did they use the right terminology regarding addiction? Did they have undue strict prescription requirements? Did every place that had an opioid need to have a safe under lock and key? I mean, certain restrictions that you would think were trivial, but yet were literally preventing patients. Even in the United States, one of the major limiting factors to the availability of opioids in our nursing homes was the lack of a safe. This is policy. And yet so trivial and yet so important. And it took really a period of time to be able to understand these sort of minimal barriers. The WHO, as I said, this is the document that was originally put forth as an Achieving Balance document to assess policies, and then subsequent to that, oh good, you can see it better. This is the newest publication in 2011 on ensuring balance, which is a much more robust document that Willem Scholten, who currently is the director of the WHO Controlled Substances Program, has been able to bring forth. And this is agreement by the WHO and the INCB and the Committee on Narcotic Drugs as to what the policy might be. So let's look to what happened in different countries. So Romania has been probably the best published of these. There's been a series of papers in Lancet that have described the policies in Romania. So here in Romania, one of our Eastern European countries where we initially had a foundation, we had a wonderful champion in Daniela Musso. So we had a champion. There were serious regulations, for example, that had been on the books for 35 to 40 years. No independent prescribing authority beyond 3 days. So after 3 days, a patient or a family had to go someplace else to get a prescription. Imagine if you lived in a rural area, how would you get back to where you would get this prescription? There was a limit of 60 milligrams per day of morphine. Every bit of science we know is that the dose of opioid that works is the dose that works. There's a concept of opioid responsiveness that we have studied elaborately, and this limit of 60 milligrams has no scientific basis. With very complex authorization, which included the oncologist, the local primary care doctor, and a counsel reviewing the patient and signing the piece of paper, could you get a 10-day prescription? And this was burdensome for the physicians and equally burdensome for the family. So now, prescribing authority is granted for 30 days. And for physicians who have specific specialties like oncologists or have received specific training in pain management, they are allowed to prescribe at this 30-day rate. So again, there's a little bit of control here, but not necessarily bad, because we clearly want physicians to be trained in how to use these drugs appropriately. There's no limit by patient diagnosis. So it's not just the cancer patient who might have gotten these drugs before, but now the AIDS patient, or the patient with TB, or the patient, just the elderly geriatric patient, or the patient with MS now has access to these drugs. And there's no limit on the daily dose. So amazing changes that have, in a way, revolutionized care at a very technical level. So what continues to be the challenge in Romania is educating the healthcare professionals. And this is the challenge that we have for the world, not simply for Romania. So what about Colombia? So Colombia is probably, you know, the most famous country for drugs in the world, but patients can only get a 10-day supply originally. This has now been moved to 30 days. One of the biggest difficulties in Colombia was that you had to go to a central pharmacy, which was typically in one of the main cities. And typically those central pharmacies were only open 5 days a week, not 7 days a week. So in this wonderful next piece that was published in one of the major Colombian newspapers, this was written to the paper, "Cancer is killing us, pain is killing me, because for several days I've been unable to find injectable morphine in any place. Please, Mr. Secretary of Health, do not make us suffer anymore." This was a little piece that became a bigger piece, wonderfully social networking that has done this, that became a major cause célèbre in the country. The Secretary of Health was enormously embarrassed by the fact that this didn't happen, and he immediately was able to change the regulation to make sure that in every area there would be a pharmacy open 24/7 for the prescriptions of opioids. So policy is good, but advocacy is really good if you have a Secretary of Health that might listen. Now, not many of us always have those Secretary of Healths, but at least in Colombia there was enough of an outcry, and it was a cancer patient for whom there was enormous sympathy, and a mother that made this a very visible issue for her daughter. So I'll come back to the advocacy issue. Guatemala is, again, a very interesting country. Again, they've been working to improve the morphine supply. They've been working on this really since 2009, where we helped the government create a national estimate requirement for what drugs they would need based on the needs assessment we've done in the country, where we have an international pain policy fellow that's supported by us with the support of the group at the University of Wisconsin that does pain policy studies. So the next positive is the first prescription ever written in Guatemala for an immediate release morphine. Now, Guatemala is a pretty advanced country. If you've ever been there, you can get most any drug anywhere in the country, but you can't get oral morphine except now. You can get it with this process. So this is extraordinary because if you are a cancer patient, you can get a bone marrow transplant these days in Guatemala, but you can't get oral morphine. I'm just making the contrast of how the regulatory environment makes such a difference, and Guatemala is one of the examples. So a success. Another new success I attribute to our UICC colleagues who have worked on a program called Global Access to Pain Relief. One of the difficulties in Nigeria was that morphine was allowed in the country, but they had no distribution system. So it wasn't so much an access issue, but it was the distribution system. There were enormous safety concerns about how the drug would be transported in the country. And the government authorities were not clear about what the exact problems were. So again, to the UICC, who has put together this global access to pain relief strategy. Oh, sorry, I thought I had that slide there. They've put together now a wonderful report with the government of Nigeria to look at how we could create a better distribution system. But part of this initiative is much broader, and what GAPRI has done has been able to find a supplier, because they support supplier networks, who will supply morphine to the country, and the government, as recently published in the New York Times, has bought 55 pounds of morphine powder to make it available for patients with pain in the country. And brilliantly, GAPRI has been able to obtain philanthropic funding to support a fellow who is seconded to the government of Nigeria to help them look at their regulatory environment, look at their distribution system, and help them improve it. So very specific, targeted approaches of drugs and technical expertise to change policy in the country. Serbia, through an amazing grant from the World Bank, has had pretty significant difficulties of access to opioids. They would be available, but only to some patients and only in the Belgrade area, and you had to have cancer and you couldn't have other diagnoses. And so the government then, with this support from the World Bank, and put together and supported the government to create a national palliative care strategy, saying that opioids were essential, that there was a need to look at national drug policies. And this has moved forward, again, quite dramatically. There's a wonderful champion, Snezana Bosniak, who's led this initiative, and she too is a pain policy fellow at the University of Wisconsin doing this kind of work. Armenia has similar problems, and I can continue to belabor each of these problems. The government is willing to have morphine, but they can't find a company that will import morphine because they don't see a market. So the next issue then is to become sort of the technical expertise of companies that will then be willing to supply drugs to these countries and whether they see an appropriate market. So wonderfully, the person, Meg O'Brien, who runs this Global Access to Pain Relief Initiative, most wonderfully, Meg had previously worked for the Clinton Foundation and had done a lot of negotiations with the pharmaceutical industry about how to make drugs available for AIDS in Africa. So she has that expertise that she's now taking to the morphine issue to be able to address these issues at a country-to-country level. And these are some of the names and the places of pain policy fellows that have been at the University of Wisconsin, and only to suggest that policy makes a difference when you have individuals who understand what drug policy is, that learn the technical expertise and bring it back to their country. So this is a group who've come from Sierra Leone, from Colombia, Argentina, Uganda, Nigeria, Serbia, Panama, and Vietnam. And for the most part, most of those countries have moved forward because this individual spent 15% of their time with a lot of expertise from Wisconsin to do this work. At the same time, another set of fellows, 6 from Jamaica, Nepal, Armenia, Georgia, Guatemala, and Moldova are sort of moving this forward. And recently, the Lance Armstrong Foundation has been willing to support a next set of about 8 fellows who will do this type of work. So really, credit goes to these individuals at their country level moving this forward and making good policies. But another approach to this issue is there's the symbolic language, there's the technical expertise, and then there's the shame and blame. So in comes Human Rights Watch. And they're really good at shaming and blaming, and so their first report they did on pain was in India, where they looked at India's obligation to ensure palliative care. It's an extraordinarily compelling report. Dr. Raj Gopal, Dr. Suresh Kumar, leaders in palliative care are sort of the focal points for this. And the person interviewing these patients was someone who'd interviewed torture victims. And his experience with India sort of made him view that there was torture. He said, you know, I would interview torture victims and I would ask them how they viewed the torture and what it meant to them, etc. And to a person, they would always say, I know it was going to end. When I talked to these patients, they said they saw no end in sight. And he said, that changed my mind as to why I might think this could be torture. So India, and this is a patient of Dr. Raj Gopal, curled up. This is a photograph by the Human Rights Watch group, pulled up on the floor. And then he's given his dose of oral morphine. He's able to sit at the table and start talking with him. There's a wonderful video on the Human Rights Watch website that you might look at that talks about India in much greater detail. So let's go to Ukraine, which is not a success story. So Ukraine has very low morphine consumption. And it relates to the fact that the rule in the country is that patients can only get 50 milligrams of IM morphine a day. So again, to the credit of Human Rights Watch, we've done a really extensive study of availability of pain-relieving drugs for patients with cancer, HIV, AIDS, or for the elderly, for patients with arthritis. And this report basically says that Ukraine is not meeting its obligation. After the report was released, the Secretary of Health was resigned from his office, who we'd like to think we had some relationship to that, but we're not sure. And he was at least slightly favorable to us, so we're not sure how that worked. But subsequent to this has been an enormous advocacy campaign about a patient, Vlad. And like, again, advocacy can be very prominent. So Vlad has a neurologic disorder with metastases to his spine. He's paralyzed. And in this video, which is on the website that you see here, he is only allowed to have 50 milligrams of IM morphine a day. And his mother injects him, although that's illegal. And nurses come to the house when it's convenient for them to come to the house to inject him. And so the story that you see is Vlad, cared for in a lovely apartment by his mother, He's fed, he's washed, he's cared for. His friends come to visit. People provide as much support for him. And it's only the government that seems to not want to allow him to have access to pain-relieving drugs. He was sent home from the cancer center with the great statement, "There's nothing more we could do for you." And this is quite prominent there. So this is, and I'm not being overly critical of the Ukraine, but then in a way I'm being very critical of the Ukraine, because here's a policy that has no scientific basis, that the government doesn't even know it has. It doesn't know its import, and this report at least has called attention to it. When the doctors were interviewed as to why they would go along with this, they basically said, this is our dual loyalty problem. We want to do the right thing for the patient, but we don't want the government to put us in jail. And they will do that to us. So this is what happens in closed societies. This is what happens in regulatory environments. And so Ukraine has started a major campaign, and these are the series of slides that are part of this campaign. This is an experiment. We've not participated in such campaigns to the present time, and we'll see if it works. It seems to be, but these are now billboards around Kiev and major cities. Pain crippled me, seeing my patients suffering and not being able to help is killing me, so this is sort of the doctor's perspective. The pain relief only lasts for 4 hours, the rest of the day I live in hell. And these are real patients, real quotes, real issues. So will this campaign be better to influence the policy that to date we have a national, we haven't done a palliative care needs assessment. We have a national task force. We have had stakeholder meetings. We have some champions in the country. But the second problem we have, like Armenia, is we don't have a drug company that wants to sell drug to Ukraine. So the policies that we might be able to change, we then need to deal with the access issue. So let me close with a few positive points. Uganda, again, I think you may well be familiar with the incredible, successful Ugandan story. And this is work that Anne Merriman played a major role in, Robert's been involved with, Jan's been involved with. The government did all the right things. It developed a national palliative care plan. It developed new drug regulations. It just happened that charismatic Anne Merriman absolutely befriended the Minister of Narcotic Policy in the country. So I don't think he could have done anything else other than change the policy because she's such a charismatic character. They developed country estimates, and they came up exactly with what they might need. And then, wonderfully, Uganda, as they was redoing their health plan, they've included palliative care as an essential service. So this is a real policy now being paid for by the government. Liquid morphine is on the essential drug list. There are new guidelines for it, and nurses have been trained, as well as clinical officers, to write prescriptions for opioids. So very, very forward-looking, with all the right elements, the right champion, the right policies, the right kind of advocacy. So we see this as a positive example. It is not to suggest that everything is going well in Uganda at this point in time, because all of these can fall apart in a moment. One of the things that were falling apart was that they changed how the drug would be accessed and delivered. And so now, again, with the support of the Global Access to Pain Relief Initiative and Meg O'Brien, Hospice Africa Uganda is basically the pharmaceutical company and distributor of morphine for the country. So they have had to take on this business role to make morphine available in the country. It's sort of a new initiative for a hospice, but it's an income-generating initiative, so it might be a good thing for them. With that, Georgia, where we work, there's been a lot of positive perspective from both the government, from the First Lady, who's been a major advocate for hospice and palliative care. They had oral morphine in the country. The new regulations allowed for not just one opioid, but two to be written on the same prescription. So morphine and oxycodone, or morphine and codeine, could be written on the same prescription. Primary health care professionals can write this. But when you go to get your prescription, you have to walk into the police office and go past the desk into the back where the pharmacy is. So the pharmacy for opioid drugs sits in the police department in every major city. It's a little intimidating for people. And it's only open, that particular desk, from Monday to Friday. So we did a lot in Georgia, but a lot more to go. And I think as we see this, the requirements that you have to get the drug at the local police station are not the most positive way to get people to think that these are safe drugs that they might want to take for the treatment of their pain. So another policy that seems to be one that we need to deal with. So Vietnam, again, an extraordinary example, a series of wonderful champions in the country, with the country now being ravaged not simply by a cancer epidemic, but by an AIDS epidemic. And so there was as part of the funding, our US funding called PEPFAR, for AIDS treatment, there was a rapid assessment analysis of what were the palliative care needs of the country. And Eric Krakauer, who's at Partners in Health, led that initiative. Basically, the Minister of Health then said, we could put together detailed guidelines for palliative care for cancer patients, for AIDS patients. And then they have recently come up with new guidelines. And so this is a photograph of Eric with Madam Chen, who is sitting there at the desk, who happens to be the narcotic officer in Vietnam, who's helped change this legislation. And then here you see this wonderful commingling of Henry Dudungo, who's from Uganda, helping the group in Vietnam about how they might change their laws. So we now have these wonderful young palliative care experts who know about policy, who are helping each other at different country levels. And in a way, the group in Uganda felt that the group in Vietnam had a lot of common similarities to the issues that they were facing. So the last of our studies is one that I don't suggest that you repeat, and that is our Southern African Foundation wanted to look at the policies in 10 countries in Africa. And so this was led by the African Palliative Care Associations. It's a very, very elaborate study. And basically what it shows is that when we looked at these 10 countries, that across the board, there weren't any policies in the government for palliative care. There were no policies in the government for opioids. This group has met with the stakeholders in the country. As you can imagine, the government's accused us of having looked at the wrong policies, of saying that there were other policies, couldn't even find the policies. So I don't suggest that these non-targeted, non-specific policy approaches get you anywhere. And we feel this way about this. I think the African Palliative Care Association feels this way, that if you're not specific, if you don't have a champion in the country, if you don't have a way to really do this internally rather than externally, then you're not going to be as successful as you'd like. So we don't think this has worked. So let me close by saying there's just such, I think at the moment, extraordinary opportunities to take the technical expertise that exists in developed countries and some developing countries to move it forward to make these policies possible. And that policy change can make an enormous difference, but only if there's implementation, only if there's technical expertise, and only if there's some sustainability. And the sustainability that has to be, and I think we've all learned that again from this country, is if we don't have physicians who are trained to do this, if we don't pay them to do this work, if we don't have policies in place, and if we don't have the government supporting this, we are not going to keep this as a growing policy initiative. So the good news is there's a lot of great policies out there. Hopefully there'll be new model legislation. Clearly the work of the International Association for Hospice Care, the Worldwide Palliative Care Alliance, the WHO have tried in major ways to support these kinds of policy initiatives. And I have special thanks to Olivia Dix and to the Diana Fund for the kind of work that they've done in Africa to move this forward. And again, many of you have participated in here. So thank you, Irene. Thank you for the research that you do to drive this policy. I think there's lots of opportunity.